Start recording. I'm sorry, I can't tell if yeah, I did. Okay. All right. Hernias. We do see hernias a lot in ultrasound, and diagnostic ultrasound is one of the better ways as far as imaging is concerned to see, because we could do things live with a hernia, which you can't really do live with MRI or CT, and that's kind of nice. Because one of the things, let's see, how am I going to say this? There are a couple of types, 3 words that we need to know. We'll look at these different locations for hernias in just a second. The first thing is kind of a weird way of doctor speak. Reducible hernias. Make my pen a little smaller. A reducible hernia is one that can go back. So a hernia, just quickly, if you look over here on the side, you see that it's a organ, or it's fat, or it's something protruding into a location it's not supposed to be. That's just the general term for a hernia. Reducibility simply means that it goes back either on its own, or you could easily push it back. Like if I took my thumb and pushed down on this hernia and it went away, that's technically reducible. Or if I relaxed and it went away, sometimes when we push, well, that's another term I'll give you, reducible. Doctors use this term, that's an E, right? Reducible. Doctors also use this term like for broken bones. They reduce, if it's a compound fracture, the bone is separated. Reduction is actually putting it back together, which is just always kind of a fascinating term for me, because I never made any sense. Let's see, I think the next one we will do is incarcerated. Incarcerated. All right, incarcerated. All right, close enough, guys. Incarcerated as in incarceration, as in going to jail. If you are in jail, you are incarcerated. So that means it's no longer reducible. That means I go to push on this hernia over here, and it does not go back. It cannot go back. It's too much out here, and too small of a hole that it went through. So that's a incarcerated hernia, not to be confused with the other term for that, or for a more significant term, is something that's incarcerated can also be strangulated, as in strangled to death. That means no blood. So if a hernia pops through, like in this case, the abdominal wall, it becomes stuck, then it's incarcerated. If it becomes stuck and the blood supply is cut off, it is now strangulated, and obviously that is very bad. Strangulated hernia is eventually going to be dead tissue, necrotic tissue.
So incarcerated would be stuck?
Incarcerated, stuck, like you're in jail.
Okay.
So, and there's one other term that I'll bring up shortly. Our locations typical locations for hernias. The first we'll talk about is the epigastric. Well, that's in the, of course, where is my, oh, there we are. Somewhere in the epigastrium. Remember we learned. So anywhere there. But of course, as you see, these seem to occur in certain places. Ventrally speaking, they typically occur along the linea alba, because that's considered a weak spot. So an epigastric can be right here, here, here. Let's even down to there. Beyond that, we start to talk about umbilical. So it is a weak spot. The total linea alba is a weak spot, and this is an epigastric. An umbilical, as you might guess, is usually involves the umbilicus itself, because that is definitely a weak spot. That is a location where your umbilical cord went through your body in utero, and therefore, right dead center, it has very, very much of a weak spot. But the umbilical region could be anywhere along that line right there. Spigelian, and I had to look up the pronunciation on that. Spigelian is also a ventral, but it falls along this line. Could potentially be all the way up to here, but they're far more common all the way down there. Remember, this is an aponeurosis going across. The linea alba is part of that aponeurosis. And this lateral, I'm sorry, I guess it's the Spigelian. It's lateral to the rectus abdominis. There's another basic, almost like a second linea alba, is another line along there. I believe that is called the Spigelian line. That is another potential weak spot. The obturator, I've got a picture for that one, but there is actually, I'll just draw really quickly. If I draw oh God, looks like underwear. Nope, can't draw it. So if I can't draw it, don't do it. I'll show you that one in a second. There's a canal actually built within the pelvic bone itself, and an obturator hernia can occur. A femoral hernia, well, that is along where the femoral artery and the femoral vein and lymphatics and nerves travel from the pelvic cavity into the thigh. And so anywhere where you have a weak spot where a blood vessel is traveling through from one cavity basically into another, that is considered a weak spot and likely to have hernias. The inguinal hernia, we mentioned this the other day, far more likely for a male to have an inguinal hernia, but it is possible for women as well. Inguinal. And what else does this picture? Oh, yeah. I'll mention others. So we mentioned the epigastric. Oh, if it's low in the body, as I'm drawing over here, still along that linea alba, it could be considered a hypogastric, or below the umbilical region and really the pelvic region, the hypogastric. Incisional, anytime doctors slice you open, let's say this guy just had his kidney removed, that of course is a weak spot, and they can have a hernia as well. And a sports hernia, which is actually not a hernia. I have an image for that, so we will look at that shortly. But if you're ever given the diagnosis of a sports hernia, you're going to expect to find something very different than what a normal hernia looks like. So we have a typical hernia here. Let's just say this is an umbilical hernia. It doesn't. It could be anywhere along the linea alba, possibly Spigelian, but most likely linea alba. What happens is that you have a weakness. Perhaps this person lifts really heavy weight and creates internal pressure inside of their body, which eventually creates maybe like just a little bulge at first, and then that bulge starts getting bigger. And my cat has decided to join us, so you gotta go, buddy. Where have you been, cat? And of course, it gets bigger and bigger. At first, the first thing that starts coming through is not so much intestine, but a little bit of fat. Maybe the peritoneal wall starts poking through a little bit more and more. And then eventually it gets big enough where not only fat is going through, but actual intestines are coming through. When we see this, there's a couple things we do. Now I'll come up with that other word. One, please don't eat that. Oh, yes. Valsalva. Oh, the Valsalva maneuver. When you ask your patients to Valsalva, you're not going to ask them to Valsalva. Most people don't know what this word means. What you are going to ask them to do is bear down. Is it bear as in like teddy bear, B-E-A-R? It doesn't matter. You ask them to bear down, or hold your breath and push on your belly, or pretend you're having a bowel movement and you need to push. That is a Valsalva maneuver. It's also, and that creates large or increased pressure inside of the body. And so what oftentimes will happen is that the patient will say, whenever I stand up, I feel this bulge sticking out. Of course, they're laying down on their back. You could have them stand up and see this bulge occur, or you could just have them lay down and you say, okay, well, bear down for me. In other words, take a deep breath in, squeeze your muscles, and kind of push, of course, without pooping the bed. But and what could happen is that all this intestine can be inside and then suddenly shoot outside of the body. And then when they relax, it goes back inside the body. And like I said, if they complain about it when they're standing, well, you could have them stand. It's just a little awkward to scan someone who's standing up sometimes. So that's the Valsalva. Oh, and the other thing, when we see this defect, this hole here, we're going to make sure that we measure the size of the defect. Doctors want to know what the size is. Okay, let's move along here.
Sorry, Kurt. I'm sorry, Mr. F. For the ventral hernias, I know you listed 3 of them, but the book also lists hypogastric and parabolic. Do we need to know those as well?
Yep. I did mention hypogastric, but I didn't write it down. Here, let's back that up.
Sorry, I put it on the group, on the little chat, but I don't think you got it, so I had to interrupt you. I'm sorry.
That is quite all right. You're more than welcome to. Why don't I have my chat? Whatever. All right. Yeah, just go ahead and interrupt me, guys. Down here. So with the linea alba continues down, all the way down. This would be the, yes. That's the hypogastric region. And what was the other one? The incisional or?
Umbilical. Sorry, para-umbilical?
Oh, umbilical and para-umbilical would be the same.
That one. Okay.
Yeah. No worries. Glad you asked. Okay. And so if you're going to be looking for a hernia, male or female, obviously they're going to have to remove their pants and underwear. So we cover them with a towel as best as we can. And we're looking right in this area, male or female, especially male, of course, but I usually start low and I work up. You know what? I really should have grabbed some pictures. Although actually good pictures of this are hard to find. I have looked in the past. So a sagittal image here, it would be considered a sagittal inguinal canal image. And I work my way up, until I come up to about this level, because up here, well, this is all the let's go ahead. The peritoneum or the peritoneal cavity. In other words, a part of the abdominal pelvic cavity where the intestines are supposed to be. But if I have this patient, and oftentimes a patient I'll have them Valsalva, and I will see fat, maybe intestines come down. And then as soon as they relax, it goes back. If you're able to store a cine loop of that, that's perfect. If not, what I would suggest is you cine back and then take picture as the hernia is traveling. Yeah, before the day's over, I'll definitely, in fact, I'll get some video, hopefully, of a hernia in action, so you can see what that looks like. The other possibility for this person is to have a femoral hernia traveling this way. I know we saw this picture yesterday, but it's worthwhile looking at again. Like I said, this is the peritoneum up here. Let's call it peritoneum cavity up here. That's where everything is supposed to be, with an indirect hernia. And I'll be honest, I don't quite understand the difference or why the terminology is direct versus indirect. You would think this would be direct, but an indirect inguinal hernia, everything is pushed down, and these can become quite dramatic. These can become incarcerated or stuck by virtue of the fact that so much has gone down that you're never going to push it all back in. Probably not incarcerated in such a way that it simply can't get back in because the hole is too small, but simply incarcerated because so much has gone in.
I have a question.
Yeah.
So for that case, can guys get pregnant? I mean, I mean, can they get the girl pregnant since it is like pressing on the lining?
They would have difficulties if it's small. I mean, if it's reducing, if it's going down and then going back, that's a small hernia, and I don't see where that would cause too much problems on fertility. If material, fat, and intestines stay down in here, of course, well, now you're raising the temperature of the testicle, and that could cause infertility. I have a picture coming up that this guy's not having any babies soon, but yeah, I mean, I guess there are some concerns for fertility. The other thing that could end out inside the scrotal sac are, I'll just draw it over here, enlarged venous blood vessels, enlarged veins all around, and those cause infertility by heating the testicle itself. But that's a different subject entirely. And so a direct inguinal hernia is not one that travels through the canal. It doesn't do that, but it actually kind of takes the canal, the first part of the canal, and blows it out sideways. Or I think the book actually reads that it's the posterior floor. So I think a more accurate picture probably would have been going off in that direction. In either case, a Valsalva will oftentimes show forward and backward movement of the intestines. Okay, I actually have a hidden picture here. I didn't want you guys to be scared or distracted by it. And I have seen these. I have done scans like this. And typically what happens is this man has no access to medical care. Let's see, it says California at the top. So this has been many years with intestines. His intestines, a large portion of his intestines are down in the scrotum here. If you're wondering where the penis is, it's hidden behind the tissue in there. So it's been engulfed basically in all this extra tissue. Typically, when I see people this bad, they're homeless, they have no money, they have no insurance, and this is not a surgery, unfortunately, that people do for free. So it is possible to see these. It's a little terrifying. And what you will actually find is intestines with peristalsis, food going, consumed food going through there, and you probably will not find a testicle because it's hidden behind all that. So.
Great question. Like with that, you like necrosis. Why hasn't it happened yet? Or
because
eventually is it going to lead to that?
Because it's not strangulated. I couldn't forget the word. It's not strangulated, so there's still.
So it could be that far down.
Yeah. He's got blood supply to his intestines in there, and so they have not. If he did not have blood supply to that, he would die because you can't lose that much intestine and still live. But
a little kangaroo pouch for his intestines there.
Yeah.
Sir.
Yes.
So that would be considered an indirect hernia?
Yes.
Okay.
And that's just horrible. Now these, oh, wait a minute. Okay, sorry, had to do it. This is an umbilical or para-umbilical hernia. We actually oftentimes see these in children as well, in babies. And in babies and very small children, toddlers, these can go away over time as the abdomen grows. But obviously this gentleman needs surgery. And actually I had a patient, or I'm sorry, a student with one of these, except his was probably about that big and stuck out a considerable amount. So like I tell you, I'm going to find stuff on you guys. Oh, this is an interesting case. And actually you have a picture very similar, maybe even the same patient, although not the same exact pictures, but in the book. And I don't know how you get a baby to Valsalva. Probably when they cry, they increase, or when they're in the middle of a screaming cry. This is peritoneum down here. You could see that there is gas, and that's intestines down there. This is a female. And so, like I said, you don't see this as much in females, but a little female baby with a, let's grab another color, hey. That's actually a little tiny uterus, and it is already, seems to be poking through what I believe would be the peritoneal, or maybe even the peritoneum's down here. It's hard to say for sure, but in any case, uterus poking through, definitely poking through. Maybe this is in, as she continues to scream, this is definitely intestines down here. This is a little, I can actually see the little bit of an endometrium there, the inside, the portion of the uterus here. And then she even was able to push ovaries. And oddly enough, both ovaries through one side, which was pretty strange. So yes, herniation of uterus through the anterior abdominal wall, uterus and one ovary in the herniated sac at labia, both over, yeah, okay. In the herniated sac at the labia majora, both ovaries, yellow stars, I guess those two, have periphery-oriented follicle. That just doesn't matter. The follicles are just normal ovaries, just in the wrong spot. And oddly enough, you wouldn't think it, but for a male, a indirect hernia goes into the scrotal sac. Female, it could actually go into the labia majora. Obviously, there's not as much room there, but there actually is potential space within the labia majora, because the labia and the scrotum are really the same thing. I mentioned the sports hernia. It's not really a hernia. And if you look closely here, actually, I'll zoom up a bit more. They call it a hernia because it's in the same exact spot as so many hernias occur, right there in the inguinal canal area, in the inguinal femoral canal area. But what they're showing here is a tear in the muscle. So if the doctor suspects a sports hernia, well, you go ahead and look for a real hernia. But in not finding a real hernia, then you look a little closely at the muscle and see if you could actually find a tear in the muscle. It is possible to do. that's a sports hernia, kind of a fake hernia. I wish they wouldn't even call it a hernia. Oh, and I mentioned I have a picture for the obturator. So the obturator muscle, it's actually not this muscle going down. The obturator muscle is going this way. The obturator canal is here, and then that's kind of like that hole. Here's the front of the right pelvis on this person, and there's, you know, if you've noticed, if you ever looked at a skeleton, there's a hole in the pelvis right there, and you know that is for different things to go through. But one thing that's not supposed to go through is a piece of intestine, and so the obturator canal is a fairly uncommon, but another possibility for hernias. Oh, okay. Let me just look at my notes. Inguinal hernia, 10 times male predominance, especially the indirect. And the direct hernias also tend to be elderly men. Yeah, that's all my notes for that part. And just to finish up this chapter, we start with some neoplasms. Of course, this is a neck, but it was a good picture. Lipomas could occur all over the place, and all it is, get away, is a fat tumor. And so this person has a fatty tumor on their neck. Lipomas are soft, they are immovable, and they're pretty common. My dog has a couple. And fairly recognizable. So a lipoma tends to sit inside of fat. So if you have fat or a fatty layer, let's say just under the skin, you'll see that this lipoma is sitting inside of that layer. Now, the echogenicity of lipomas tend to be fairly echogenic. Well, fat tends to be fairly echogenic, but that depends on where you are in the body. So lipomas are not always echogenic, and I would say this one is really not echogenic at all. It's pretty much isoechoic to the tissue out here. This is subcutaneous fat over here as well. So that's a fairly typical image of a lipoma. Those are common. Let's see, we have, let's get a little less. We have a desmoid tumor here. Desmoids can occur anywhere. This one actually is a rectus abdominis desmoid tumor. They occur in the presence or from connective tissue. They are generally benign, but they can be locally invasive. So they're kind of pseudo-cancer. They don't metastasize. They're not going to kill you because they don't metastasize, but they can locally invade and be a bit aggressive. They have Doppler internally. The thing about cancer is not a thing. Cancer is many, many, many things, but the one thing that all cancers do is grow. And so it's cancers are uncontrolled growth of tissue. And sometimes a tumor is just simply an uncontrolled growth of tissue that also expands its boundaries or is invasive or has metastasis. So this guy is invasive, but only locally. He's kind of he's kind of on the cusp of almost being cancer, but not quite being cancer. The next one was this, I showed you this the other day. This is endometriosis. This is something only women can get because it is from endometrium. They're finding them a little more common today because of the preponderance of C-sections. And so when you have a C-section, you open up the uterus, and endometrial elements can leak out of the uterus and find their ways to other parts of the body. So this person has what was supposedly confirmed, although recall that I think your book has a different explanation for this exact same picture, but supposedly this was confirmed to be endometriosis at the umbilicus. So right under the belly button, she had pain, she had monthly pain, and this is what they found. Endometrium is, let's see, how do I say this without scaring 3/4 of the class half to death? In a way, endometrium is a fast-growing tissue. There is a reason why endometrial cancer is fairly prevalent. It is fast-growing, almost invasive type tissue. And in fact, endometriomas that are placed around the body can rarely, doesn't happen all the time, but they could actually become a sarcoma. The cancers are funny. They can be caused by all sorts of different things. It could just be genetics or a change in your genetics due to radiation. It could be irritation in the body. When people have lung cancer, they have a mesothelioma, it is from asbestos in the air. Asbestos is all it is a basic piece of earth. It is a mineral, but it's a mineral it's all kind of spiky and everything. And once that gets into lung tissue, it irritates the lung tissue around it. Irritated tissue over a number of years can become cancerous. So that's just a little off topic, but I think interesting just the same. Okay. So this is a sarcoma. It's actually on, I assume, a female. This is pectoral muscle. Above the pectoral muscle or anterior to the pectoral muscle will be a little bit of breast tissue. This is just a little bit of breast tissue, so it's probably a little on the periphery, not directly centered on the breast. And then a little bit of fat tissue. So this is actually breast tissue, fat tissue, and a sarcoma, which was, in this person, was mistaken for breast cancer. It actually wasn't. It just happened to be in the same place as breast cancer, or very close to the breast. It's just in the muscle and not in the breast. Therefore, it was not breast cancer. Sarcomas are also connective tissue, tumors. And I think the last of the neoplasms, oh, by the way, go away.
Kurt.
Yes.
Sorry, Mr. S. For neoplasms, I also have neuromas. I don't think we went over that though.
You know what? Because I didn't find a single good picture. I will. I'll talk about neuromas. New growth. So a lot of people, including we had a nurse come to our class and tell us that a neoplasm is cancer. No, a neoplasm just simply means new growth. Cancers are neoplastic, but then again, so is a lipoma is also a neoplasm. Just simply new growth. Doesn't necessarily mean cancer. And last picture here, this is metastasis of the abdominal wall. I forgot what kind of metastasis, but, and boy, this looks, if this were a breast, this would be a concerning shape to it. Benign, and this, okay, I'm going to get into things I don't need to, but just suffice it to say that as if the growth is irregular, it's a little more likely to be cancer, or in this case, metastasis from a distant spot. So this could be skin cancer, could be ovarian cancer, colon cancer, something traveled to this spot and created a little cancer there. Neuromas, and yes, I did not. So a neuroma, okay. Wow. Nerve. Cut end and swollen. So the reason I didn't include this, and it's an R here. The reason I did not include this is when I started to look this up, I wanted to find, at least an image, could not find a single neuroma of the abdomen. Now, and it's a cut end, so probably post-surgical neuroma. And so every one that I found was either in the hand or the foot. And maybe I could do a little more research just to find out why that is. But it seems to be pretty uncommon for them to not ever include that. Okay. Problems with the diaphragm? Well, right here we don't necessarily have a diaphragm problem. We have a pleural effusion, and all of this area, you're not supposed to see that. This is all fluid. All fluid in there. Looks like the fluid even extends up high, which is significant because this person's laying on their back. And you expect fluid to be dependent. In other words, dependent means gravity dependent. Fluid tends to go down towards the earth. You see like a little bit of lung. With this amount of fluid, that lung is pretty much collapsed and barely functional. But in any case, like I said, there's nothing wrong with this diaphragm per se. It was just that we clearly see the diaphragm going across like that. With this patient has eventration of the diaphragm. This liver is way up here, probably pushing the heart a little bit too far to the left. In fact, it is pushing the heart a little bit too far. The whole mediastinum, and mediastinum is basically this area, including the heart. Everything's a little bit pushed off to the left on this patient. Eventration can occur because of, it could be developmental, just could be a weak spot in the diaphragm, and it's allowing that liver, which is under higher pressure, to push up. Ascites can increase the fluid pressure, the abdominal pressure, ascites being a large amount of fluid in the abdomen. That could push it up, or it could be paralysis. So a lot of times people have hemiparalysis, half paralysis of the diaphragm. So you could have a normal diaphragm, a normal functioning diaphragm on this side, but a paralyzed diaphragm on this side will eventually stretch out. I had kind of an embarrassing moment in my first job in ultrasound. I thought I was hot stuff, and I had a pretty big guy I was scanning, and looking for his liver, scan. I couldn't find his liver anywhere. In fact, I thought I saw the liver. I could swear I saw a normal, let's see, it would have been more down here. I thought I saw a normal liver shape. And I think I even measured it. I went to the doctor. I said, this guy looks like his liver is entirely filled with cancer. I can't even see normal tissue at all. And then the doctor pulled up his CT exam and saw that his liver was probably even higher than this person. His liver was all the way up in his chest cavity, and all I was scanning was intestines, liver-shaped intestines. And it was really embarrassing, but the doctor was pretty cool about it. He says, Kurt, how would you have known? Because actually the person had not had a CT at that point. They saw the CT afterwards, and then the doctor called me. He says, how would you have known? He says, why would you even think to scan the chest looking for a liver? And I was like, I don't know. But so paralysis is possible. I have had plenty of patients that I wonder if they did have paralysis. You know, when we have patients take a deep breath in and hold it, the reason for that is every organ in the abdominal cavity, well, almost every organ moves down when they take a deep breath in, because that's what the diaphragm does. It moves down, and all the organs have to go down in order to make room for the diaphragm. You will have patients out there, you ask them to take a deep breath in, their chest moves up, their chest goes out, but the diaphragm doesn't move at all. And so I don't diagnose anything. I might mention to the doctor, inspiration was unhelpful. But so that is possible that some of those patients of mine did actually have either totally paralyzed or partially paralyzed diaphragm.
Yes, can I interrupt you real quick?
Sure.
Before we get too far away from it, when I was going into the homework, they had a question that was asking the difference between pleural effusion and ascites.
Ascites, okay.
Ascites, yeah.
Yep. Oh, good.
Besides, like, having to go to, like, the report of their diseases because the diseases were related to the two were different, it just says that both of them were fluid in the cavity.
Oh, interesting. Yeah, so this one, as you know, because it says it right here, is pleural effusion. Pleural effusion is in the pleural space. The pleura that's the space where your lungs are. So if you have fluid superior to the diaphragm, you know, basically surrounding the lungs here, that's a lung there, basically, that's a pleural effusion. If we're to find fluid down here, actually even, let's say, let's use a different color. If we were to say, let's see, like a sliver of fluid over here, and then maybe opening up like that, that would be ascites. And in fact, we're going to talk about that in chapter 3 a little bit more. Sounds good?
Good, thank you.
All right. Another hernia that we did not mention because it's not the same thing. It's not a ventral hernia. It's not a groin hernia. But I know this is horrible, but that actually says left diaphragmatic hernia. Now, what we're actually seeing here is a cross-section of a fetus, baby in utero. This heart is supposed to be more or less like that, actually a little more up here, but still, that heart is supposed to be over there. It's in the wrong spot. This heart is pushed so that the apex is going straight out. The apex is supposed to be more or less to the left, and it's in the right side of the baby's body here. And that's because this is all intestine. This baby actually has a defect in the diaphragm that has allowed intestine, oh yeah, and a little bit of that's stomach. So intestines and stomach are actually in the chest. So obviously very bad news for this baby. Survivability depends really on how much the baby is able to breathe out of one lung. That's a diaphragmatic hernia. And obviously a diaphragmatic hernia, this person would be born with it. What else do I have written down for? Congenital required, stomach, esophagus, maybe, okay. Acquired hernias are far less common. Acquired hernias as in like an adult getting a hernia, not simply eventration, here, but an actual hernia, an actual hole going up into the lungs. Into the lungs.
A couple of questions. Can you see the hole in the diaphragmatic picture?
In this picture, no, we can't. And what we'd have to do is do a sagittal image in this plane, and it would be obvious where the diaphragm wasn't. I guess, yeah, you would be able to see the hole. It would basically just be a place where there should be diaphragm and there isn't. So.
Awesome. And one more. Whenever everything comes up into the cavity like that,
yeah,
and it moves the heart over.
Yeah.
And they also that they're basically going off of one lung. Which system is more under duress in that situation? Your cardiac or your respiratory?
Yeah, this would be a bit of a guess, but also an educated guess. I would say respiratory. The heart, we assume on this baby, if it's normally functioning or normally created, normally formed is what I'm trying to say. If it's pushed over like this, the veins and arteries leading to and from it are simply going to adapt. They're going to grow with the baby in this weird configuration. So I believe the baby's circulatory system will be fine. But one of the major causes of fetal or death right after birth is a failure of lung development. And this baby's left lung is certainly not going to develop normally at all And even the right lung will be affected by this.
Awesome. Good stuff, man. Thank you.
Sure. One thing we could also see in ultrasound, when we go back and we think about the one of our first images is, let's see, let's make this so I could actually draw a straight line. And red on red, let's just go ahead and pick another color really quickly. Okay, so our first image is oftentimes, I think most people start sagittal at the epigastrium. And this is right at the epigastrium. You could practically, you can see this is the left, whoops. Get away from me. This is the right hemidiaphragm, hemi being two, left hemidiaphragm over here. And of course, this is all diaphragm underneath, but that's just the cut edge of the diaphragm here. And so rib cage is coming up like this. And so that's where this is where we put our transducer to begin with. And one of the things that I got used to looking at, actually, I started doing this 15 years ago before they were even really talking about it. I just kind of noticed that on some people, you could see a lot more material that you should see. And oh gosh, without a picture, you know what? I'll grab an image to show you what I'm talking about. But you could actually see a hiatal hernia on a person, and a hiatal hernia is basically a little bit of stomach popping through, just a tiny bit of that stomach popping through the esophageal hiatus. Esophageal hiatus would be the normal hole here, and the stomach's just popped through. And people with hiatal hernias also have a real problem with reflux, as in acid reflux. Let's see. Pleural effusions. Cancer. Paralysis, eventration, hernia, hiatal hernias. Inversion. Oh, inversion, I guess, is the only thing I didn't mention, at least from my notes. And inversion, well, don't have an image of it. I actually could not find a decent image of it. Let's just use this guy. If, for instance, an inversion is going to be more likely on the other side of the body because the liver is such a big organ that it stops this from happening on the right side of the body. But if we can imagine, let's see, orange, this is a normal diaphragm. It is domed in such a direction as that, but an inverted diaphragm, wow. I'm getting a little too comfortable in my seat here, guys. Let's just do this real quick. An inverted diaphragm would be pushed that direction, and that could be from a very large amount of pleural effusion, especially a pleural effusion coupled with any kind of diaphragmatic paralysis. So that would be a inverted or inversion of the diaphragm. All right. Any other questions? All right, I'm going to, let's take a break. Let's see more.
It's all good. Just start from the top.
All right, well, you know what I'll do is I'll just make sure I'll do a quick review. You know, I even have a note in front of me. Start from the top. How did you even know that I wasn't recording? Is there a...
There's a little red dot in the top left corner of our screen that says whether or not you are or not.
Yeah, see, I don't have that dot. Okay. Dang it, I really like this one too. Okay, this is another location, another potential space, and let's see, why can't I remember? Posterior suprahepatic, but we're going to call it left, I believe. Check here. Okay.
Okay.
Supra.
Hey, Kurt, is there any way you can screenshot that picture for us?
Oh wait, I just realized something. I could hear you a little better now, I'm sure. I'm sorry, what did you ask?
If you could screenshot that picture and maybe send it to us?
Yeah, in fact, I screenshot yesterday's picture as well. I'll go ahead and send that. Oh, this makes me sick that I wasn't recording the whole time. Okay. Okay, so suprahepatic. I don't know why they have to call this one subphrenic and this one suprahepatic. They're both kind of subphrenic and they're both suprahepatic, but that's just the way it is. The suprahepatic, supra meaning kind of above, is more back here, more the posterior aspect of there. And anything else? Inferior recess. Okay. I'll just simply mention, I don't think I'm even going to draw it in because it's already becoming a mess on this page. Well, you know what, I'll at least color in a little bit here. Another recess is considered down here, and in the infant, in the newborn, there is a potential space that goes all the way down to the very bottom of the greater omentum. But as we get older, the omentum fuses and you get this space down here. This would be the inferior recess. Oh my God, I just went over so much information. And for me, we could talk about we could get into ascites. My dogs are going to go crazy because the doorbell just went off. We get into ascites and different kinds of ascites on Friday, I guess. First of all, let's just remember to screenshot that. Oh, is that going to be in my screenshot? Maybe. Let's hit screenshot again. Okay. Oh, what a mess. So, just for the sake, oh God, I don't think I can. I don't think I could review this. You know what? I'm going to let you go, and I'm going to review it after you guys go. Because for you to sit here and watch me go over this again would be ridiculous. But I could sit here for 10, 15 minutes after I let you go. So let me pause recording. Okay, this is for YouTube only. I forgot to restart the recording. It's extremely frustrating. And obviously you could tell from the screen there were quite a few notes and quite a few things happened here. So, wow, where to start? Well, I guess I'll start where I left off, and that's, or not left off, but where I would have started. And that's naming a few organs in here. We have the liver here, stomach, and this is a sagittal view. Sagittal left. Patient, this is a little bit to the left of the patient, perhaps, because otherwise you wouldn't see the stomach and the pancreas. And maybe that's just the left lobe of the liver. Any case, liver, stomach. TC is for transverse colon. These are intestines, 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 intestines. We're seeing a cross section, which is why they're circular. This one's intestine too, but it's the second, the third portion of the duodenum. The duodenum is the very first part of the intestines that comes off the stomach. So you can see that for some odd reason, the duodenum goes back here before it comes back out again. This little guy here is the pancreas. This is a female, so we have the bladder, uterus, and also rectum. Okay. So what we were talking about is, yeah, that's all I want to talk about for as far as organs go. Now, the organs are created early in development from mesenchymal cells on the posterior of the embryo. They're not made in the middle of this cavity. This is, by the way, the abdominal pelvic cavity. I ran out of room there, but you get the idea, the abdominal pelvic cavity. The liver does not develop in the middle of the cavity. It develops from a little bud along the edge. The stomach, the pancreas, the spleen, all these things develop from mesenchymal cells on the posterior of the fetus, posterior of the embryo, really. As they grow out, they have to grow through something. And that something is the peritoneum. Now, as we get, let me zoom in here. As we get close, we can see this purple line that I've drawn. This purple line is continuous. It goes all the way around the outside of the body, comes back, doubles back around. Sometimes when something is turned like this, a little turn, medical people say that it's reflected, or it reflects. So it reflects around the liver, around the stomach. This is one continuous line. At least the part that's surrounding all the blue is one continuous line. And I guess this is salmon color. We have another continuous line of purple peritoneum drawn. Now, that forms two pretty decent sized cavities. The first cavity, outlined in blue or colored in blue, is called the greater sac. That includes anterior to the liver, between the liver and the stomach, all down the front of the belly, and in between all of these intestinal loops is the greater sac. The lesser sac is the salmon colored. That goes behind the liver, between the stomach and the pancreas, and down a little bit, a little ways into the, of course I didn't write it down. That's the one thing I can't remember. It's a recess, so this recess down here, the inferior recess. Okay. So those are two great sacs. It's important to know these because when you have ascites, more likely than not, you have ascites in the greater sac. And that fills fluid. And you'll see in the book, there are images of intestines just floating around. That is the greater sac fluid. The lesser sac is almost entirely separated from the greater sac. When there is fluid only in the lesser sac, it may be because of perhaps a bleed in this area, or perhaps the pancreas has pancreatitis and fluid is going straight from the pancreas into the sac. I am recording. Okay. So knowledge of where the fluid is helpful for sonographers. Okay, let me look at my notes. Omentums. Okay. As this peritoneal line goes around the liver, it reflects from the liver down to the stomach, and on the other side of the stomach, there is a reflection of peritoneum. So a double layer of peritoneum here creates what we call the lesser omentum. The lesser omentum. As that peritoneum travels around the stomach, it drapes all the way down in front of all the intestines and comes back. Doesn't come back to the stomach though. It actually, this line, if you follow it, it comes back to the transverse colon and then back to the back. And then it follows along all around. That's right. You can't always see my cursor, so I got to be careful, don't I? Let's get a little darker color here. Blue here. So, dang it, let's just make sure we have the, as this line is traveling around the stomach, it goes all the way down, back, doesn't go back to the stomach, goes back to the transverse colon, continues around. This drape of double peritoneum is called the greater omentum. You see here I mentioned omental cake. Well, the greater omentum happens to be a place where sometimes cancers do find themselves. And if the cancer does find itself there, like a metastasis, it can cake itself all over the omentum. That's why they call it omental cake. My birthday is this month. I expect omental cake. No, I'm kidding. So yes, greater omentum here, lesser omentum between the liver and the stomach. The rest of these double folds of peritoneum. They act as scaffolding. The blood vessels, the superior mesenteric artery, the inferior mesenteric artery are inside of these double layers of mesentery. Nerves, I know that's totally unlegible. And lymphatics. These double layers are called mesentery, and that is why we call it the inferior and superior mesenteric arteries. So mesentery, these hold everything together. Nothing is inside of the actual cavity, even though we say they're intraperitoneal and extraperitoneal. Okay. Intraperitoneal organs are organs that are completely surrounded or almost completely surrounded by peritoneum. I will list them. I will not write them. You have the liver, the spleen, the stomach, first portion of the duodenum, only the first portion. Jejunum, ileum, and cecum, those are intestines, transverse and sigmoid colon, and 2/3 of the rectum are intraperitoneal organs. Retroperitoneal organs are organs that may well have peritoneum over them, like here and here, but they are not surrounded with peritoneum. Those are retroperitoneal organs. Most of the pancreas is actually retroperitoneal. Kidneys are retroperitoneal. Your blood vessels, look at this. The blood vessels are, let's just do a, it'd help if I made that red like I meant to. The aorta travels behind the peritoneum. Its branches, the SMA, the IMA, the superior mesenteric artery, inferior mesenteric artery, are all, well, the aorta and IVC are retroperitoneal, and then these branches at some point would be considered intraperitoneal. Okay, so retroperitoneal, intraperitoneal organs. I mentioned lesser and greater sac, transverse colon is just parietal peritoneum, and let's zoom in on that. So remember, this peritoneal line is continuous. I can put my finger down on this purple line and follow it all the way around, from the abdominal wall to around the stomach to around the liver. However, we do call it different things depending on what it's around. If it is against the abdominal wall or against the pelvic wall, that includes back here as well, it is considered parietal peritoneum. If it surrounds a organ, such as the liver, it is visceral peritoneum. Visceral, the viscera are the organs. A lion will eviscerate its prey. It'll rip its organs out, visceral. Since I'm staring right at this, I might as well just mention the subphrenic space, the below the diaphragm space, is what I colored in green here. That is a potential space not only for fluid, but also oftentimes abscesses. The suprahepatic space is really just on the other side here, is over the liver. The bare spot is the one spot on the liver that is not covered with peritoneum, visceral or otherwise peritoneum. Oh, I mentioned that these two sacs, I already jump around a little bit here, the greater sac and the lesser sac pretty much do not communicate except for this one hole right here. That hole is called the foramen of Winslow. I think the only thing I have to mention now is that this is a female. We are more concerned about female potential fluid spaces in the pelvis than we are with males, simply because of ovaries for the most part. I'm still gonna move this up just a little bit more. Okay. Okay. There is a potential space anterior to the uterus. This is urinary bladder, uterus, and rectum. Anterior to the uterus is oftentimes called the anterior cul-de-sac. It also sometimes is called as utero, obviously for uterus. Vesicle. Vesicle is actually for bladder. A lot of times, for some reason, doctors call the bladder the bladder a vesicle. I guess because it holds fluid. So that's anterior cul-de-sac or uterovesical space. We don't often have fluid here. We very often see fluid here. And this is called the posterior cul-de-sac, also known as the pouch of Douglas, also known as the recto-uterine space. Recto for rectum, uterine for uterus, obviously. Let me look at my notes. I think I did a quick and dirty overview of everything we talked about. Yep. I think that is it. All right, I'm going to stop recording. Hope this was helpful for you all.